program.
Okay, so we'll start.
I'm just making it live half a minute. Done. Namaste, sir.
Namaste, Asha Ji.
नमस्ते सर।
नमस्ते पूनम जी, कैसे हैं?
ठीक सर।
आपके साथ हम गेस्ट ऑफ ऑनर, देखो हमारी कितनी शोभा बढ़ गई।
Okay. So, good evening, all the faculties and delegates, and
Mehul, you're live. Go on.
yeah, just a minute. So, good evening, all the faculties and delegates, and we welcome to the Searchlight webinar series 28, which is on the updates on labor monitoring. And in association, it is initiated by Cancer Prevention and Relief Society in association with Bhimavaram, Northern India, Parbhani, Pathankot, Rajkot, Raichur, Roorkee, Shahjahanpur, and Raipur Ops and Gynae Society. So first of all, it's my privilege to introduce our convener, Dr. Sujayasri Sangita. Madam is the founder secretary of Bhimavaram Ops and Gynae Society, and Madam is a consultant Ops and laparoscopic surgeon at Seshadri Hospital and Palalkot and Mallikapuram. And Ma'am has got numerous awards, Shan Ratnam Awards and Foxe Dhira Awards. And Ma'am has presented so many posters and also associated with the awareness programs Vikasam for the adolescent girls. So over to you, ma'am.
Thank you, Mr. Mehul, for that kind introduction. So moving forward, a very warm welcome to everyone who's logged in today. I would like to introduce the program director, Dr. Asha Jain, ma'am. She is the director of SMSA Hospital, Raipur, and she is currently the medical director of CPRS. She is also the elected member of CG Medical Council. She has been the zonal chair, Foxy Food Drug and Medical Search Committee, West Zone, chairman, Mission Pink Health, IMA Raipur, and also executive member of ISCCP, Chhattisgarh ISAR, and Chhattisgarh SFM chapter. The previous offices held by her, she has been the president of Raipur OB-GYN Society, vice president of IMA Chhattisgarh, and president of the Rotary Club of Raipur North. Madam has received training in colposcopy. She's also a certified instructor in the same. She has received her IOTA certification.
Currently,
she's standing. Yes, ma'am. Currently, she's standing for the chairperson of food, drug, and medical surgical equipment. So, hoping for everyone's support for the same. Ma'am, I request you to please take over and introduce the guests.
Thank you so much, Sujayasri, and thank you, Mehul. Now, I would like to welcome all the dignitaries to this platform, and I request everyone to join in for the prayer, and then we take the program forward.
Om
Ma'am, please unmute yourself, ma'am. Dr. Asha, ma'am, please unmute yourself. Yeah.
Namaskar. I welcome all of you to this 28th episode of Searchlight series of webinars. Every time we take a different topic, dealing with the updates on that topic. Today, the Searchlight falls on labor monitoring. We have as our chief guest, respected Hema Divakar ma'am. Welcome, ma'am. We have our guest of honor, Dr. Atul Ganatra, sir. Welcome, sir. And also Dr. Poonam Goyal, ma'am, the chairperson of Safe Motherhood Committee. Welcome, ma'am. We have very important speakers who are experts in their own field. We have Dr. Rashmi Bagga, ma'am, who's the president of Northern India Society, but she's also professor and HOD at PGI Chandigarh. We have Dr. Chinmay Umarji, who's known for invasive techniques and monitoring labor. So I heard that he's the only one who's monitoring labor by ultrasound in India. So he's our speaker. And then we have a panel. We have Dr. Santosh Chandak, Dr. Beena Mishra, Dr. Mangala Gadwal, Dr. Kuntal Jadeja, Dr. Manisha Agarwal, and Dr. Deepa Saxena as our chairpersons. Dr. Krishna Pawar, Dr. Prerna Singhal, Dr. Shanmugh Vidhu, Dr. Deepika Agarwal, Dr. Sarvana Kumar, Dr. Monica Pathak, and Dr. Radhika Javia as our panelists. I welcome all of you to this webinar. I hope your 2 hours will be well spent. I now request for the CV of Hema ma'am. She is one person who doesn't need any introduction, but it's always a reminder to ourselves where a person can reach. So ma'am, please allow me to read your CV. So ma'am is the CEO and chairman, Asian Research and Training Institute for Skill Transfer with FICCI Award for Excellence in Capacity Building, Division Director, FIGO Well Women Healthcare, President Karnataka AHPI, State Representative, HSSC Kerala, Karnataka, Chair Nutrition and Breastfeeding Committee CEFAW, UNICEF Ambassador for Impact for Nutrition, ex-chair of Well Women Healthcare at FIGO, ex-president DIPSI, ex-dean Karnataka College of Obstetrics and Gynecology, past president FOXY, and advocate for delivering quality healthcare, convener of Manyata, an opinion leader and influencer for social and legal issues relating to women's health. So she has the FIGO Women Achievers Award, Global Asian of the Year 2018, CME Excellence Award for Artist CSR Impact for Divakar Service Trust. Ma'am, we are really honored to have you with us and would love your insight into the topic and a few words of blessing for us.
I would say she has the Teacher of Teachers award also. Right here, I'm a student of hers from 1983 onwards.
Namaskar, everyone. Thank you for that kind introduction. And Atul, you know that anytime I'm called as a guest, these are my most embarrassing moments when somebody reads the CV and then we say that there's so much people have done and so much more they could do. And what little we've done is, read out in a manner as if, there is always more is my take on this. So Atul and Poonam, whom I've seen them grow as my children into leadership positions today, and I'm so very proud of them. And Asha, I have to tell that 1, 2, 3, 4, 5, when we are counting 28, it is very easy to start something, but to keep doing it over and over again to sustain, we say at the end of a long tunnel, there is light. There is such light for sure, at the end of this program. And then you have some brilliant speakers like Rashmi ji and Chinmay. Because when we started the Manyata program, Sujayasri is also coordinating and weaving the threads into this very important issue of labor management. We said that we are going to set from FOXY some very simple standards for safe delivery. Simple means really simple. They are evidence-based. They are non-negotiable. Every single woman who is in labor has to get, as her human right, minimum this amount of care, right? Then we came to the issue of partogram. Arey Baba, partogram kaun karega? Koi to karte nahi hai. They will put Xerox copies afterwards and they will tick here and there. And it's all just a drama that is going on. So actually, initially, the leadership thought that the 14 standards, 16 standards, what we have defined, everybody should know all these 16 standards. We cannot compromise. If they don't do this 16, then there is no way ahead. But then slowly the fingers went round and pointed towards the photogram. That is supervised labor. They said, "Nee, madam, ye to hoga nahi." They said, "Okay, then we will allow you to fail in one." That is, maybe most people will fail in this protocol of the following of patogram meticulously as a chodo. Then you 85 on 100 is your passing. And to our surprise, it is not rocket science. It's just that people do not know why they're plotting and what this actually means. Every single delivery which is supervised and the task needs to be shifted to somebody who is with the labor patient. And OBGYNs, it's like God made mothers because he cannot be everywhere. So the paramedical staff, which are with every single laboring patient, should meticulously monitor the labor so that the right signals are picked up at the right time. And a graphical way of representing that is the partogram. When we drilled this culture into the staff of every single of the 3,400 private facilities, where they said, "Man, we don't do the PV, man, we don't know." The consultant comes, then he writes, and she knows what is going on. And then we said, when you change the duties, there is so much confusion, etc., etc., etc. And the story went on. But once they understood that these many parameters are marked there, this is how and what it implies, and it is our responsibility to recognize the situation early and bring it to the notice of our boss. There was a sea change. And today, every single center who is accredited, they are genuinely plotting the way it should be. But now the WHO has changed the standards. So again, we went through the retraining and everything. It's like work to be redone. After so many years, we bought some system into the private centers, and then we had to kind of again redo. But it's so worthwhile, because when we scream so much about rising rates of C-sections, etc., every single supervised labor in itself would be a good methodology to document what's going wrong and why. So this topic of labor monitoring is so, so crucial. Asha, I really congratulate you for putting, though it seems simple, it is a very, very important thing. The next thing is the ultrasound, which Chinmay is going to speak. The sixth sense of an OBGYN is ultrasound. So for everything, and we were, laughing at people who may want to use ultrasound even at labor, but now it's also some newer thoughts which has come into place. So it's always good to keep our minds open to something innovative, something novel, and everybody takes something out of the newer advances which are coming and which will stay. So I wish that not only in your position as the future leadership of the chair, but before and beyond, before you have already proven yourself that you are on the track of disseminating the best of the knowledge that you can. And I do hope that in the strength that you would gain with the official positions, you will continue to do much more and scale our parent organization Foxy and the global organization FIGO to greater and greater heights. And may I wish the same to all the brilliant faculty and my colleagues who are cordially invited this fine evening as guests of honor. It's an honor indeed to be with my beloved people on the same screen. I wish you all the very best. Thank you.
Thank you so much, Hema ma'am. Thank you. I'm really honored to have you here. Really honored. And those words, let us see how much we can act on them, because really getting the partogram into the staff is not an easy task. And in the private, the staff keeps changing. That is another problem that has to be managed. Now, I would like to introduce Atul Ganatra, sir. He was VP Foxy in the year 2022. He's currently the president of IAG. He's an associate consultant obstetrics and gynecology at Fortis Hospital, Mulund. His areas of expertise include gynec laparoscopic surgery, IVF, and high risk pregnancy. He has various international research papers, and he has purposely made his CV so short that we can't really dilate upon it. But for high risk, he is a very, very important person, a go to person wherever high risk pregnancies come. So, welcome, sir. Welcome to this forum.
Thank you. Just a little correction, VP Foxy 2021, 2020-2021, when Dr. Alpesh Gandhi was the president. Well, I think Hema ma'am has said everything. Whatever I am today, I think is on the foundation of Dr. Hema Divakar and my teachers when I was doing my MBBS. Dr. Divakar, her husband, also was my teacher in ophthalmology, and my roots go back as to 1983. It's almost like 41 years. Madam has said everything. All I want to say is we are in the era of evidence-based medicine. And two things that I would want to say: whatever you do, whatever you write, whatever you prescribe, please follow the evidence-based method. Gone are those days when we could say, I gave this because I thought this would work, because this patient is going to go back and read on Google. And documentation, medical, legal, so many. If you are following that medical dialogues, almost every other day you see about a complication that took place during delivery, obstetrics, IUFDs, meconium stain, post-cesarean complications. I think we need to document everything that we do and follow evidence-based medicine. I wish this webinar great success.
Thank you, sir. Thank you so much. Mehulji. Now, it is my pleasure to invite Dr. Poonam Goyal, ma'am, who is HOD IVF and infertility at Max Super Speciality Hospital in Vaishali, Delhi. She is director and HOD Gynae at Panchasheel Hospital, and she is currently the Foxy Safe Motherhood Committee Chairperson, ICOG Governing Council member, Executive Member, EDGF, has edited and authored many books. And I invited ma'am because this is a topic that is very closely related to labor, to safe motherhood. So welcome, ma'am. We are eager to hear words from you.
Thank you so much. Thanks, Dr. Asha ma'am, for inviting me here today. It's my proud privilege to share the screen with Dr. Hema ma'am. And Dr. Hema, I would say, since I saw you first time, I think that was 25 years back. I don't remember. You still look
Jab
me
we
the
met moment.
same. Jab we met. You still look me the same. Absolutely, with same energy and with same efficiency. You will not be late even a 1 minute, and your talks are, they are just out of the world. Everybody loves to listen to you. And Dr. Atul sir, my regards to you also. So, in today's world of so much litigation and everything, I think the labor monitoring is very relevant, and it is must for us to know whatever is being added on the list. We must be aware of everything. So it encompasses a blend of technology as well as traditional practices. Now we have computerized CTG, we have mobile apps, we have even remote access to monitoring facilities, and now this intranatal ultrasound, though much people are not still aware of this, but still it is also coming up new. So we need to monitor. They say that now we need to assess the patient on hourly basis, and then according to that we need to monitor our decision what we need to do further. And if any intervention is needed, we have to do it timely. Otherwise, that is going to be a problem for us and for the mother and for the fetus also. And in this scenario, we will say that respectable maternal care concept has come up. And in all our decisions now, the decision of the mother and her counseling is very important. And the concept of STV on computerized CTG, Dr. Rashmi will highlight that. I think we should all be aware of all these things and why that procedure we are doing any procedure if we are doing something and we need to justify everything, as Dr. Atul said just now, that we need to justify what we are doing, and the monitoring as the things are changing, we need to learn everything. So I wish us success to this webinar and to Dr. Asha also for coming up. Thank you so much. Thank you so much.
Thank you so much, Dr. Poonam.
Thank you.
Now, we have a lot of delegates joined in. Welcome, all of you. I hope you have all benefited from the comments of our guests. And now, with due permission, I would start with the scientific session. Mehulji, Sujaya, would you please introduce our chairpersons?
Yeah, moving on to the first session, which is clinical and CTG monitoring of labor. The speaker is Dr. Rashmi Bagga, ma'am, and chairpersons, we have Dr. Santosh Chandak. Ma'am is the director of Chandak Hospital. She is the president of Parbhani OB-GYN Society. She has an experience of 37 years in the field of OB-GYN. Welcome, ma'am, to today's program. Next, we have Dr. Beena Mishra. Madam is the president of Pathankot OB-GYN Society. She has completed her MBBS from Lucknow and her master's from PGI Chandigarh. Madam is right now, she's been the past district governor, Rotary International, and she's also been the past president of a Indian Women Conference. Welcome, ma'am, to today's session. We also have Dr. Mangala Gadwal with us. Madam is a consultant at GPV Super Specialty Hospital in Raichur. She is currently the president of Raichur OB-GYN Society. Welcome, ma'am. Last but not the least, we have Dr. Gini Gupta. She is an ex-PGI JIPMER candidate, and madam has completed her master's 24 years back. She's currently the consultant at Healthline Hospital, Ludhiana. She's the president of Ludhiana OB-GYN Society. She's also a member of SFM, SMC, and AIWF, Manyata Champion and Coordinator, Punjab. So we have someone who's following the footsteps of Dr. Hema, ma'am. And currently, she has also been a faculty at numerous state and national level conferences. So it's a great honor to have you with us today. Sorry. Yeah, so I request one of the chairpersons introduce the speaker. Dr. Gini Gupta, ma'am, would you like to introduce the speaker?
No. Mangala, ma'am, please introduce the speaker.
Dr. Mangala, ma'am, yeah.
Yeah.
Mehul, you need to display the
share
CV.
the slide, please, Mehul.
May I have slide?
Yes, ma'am, he's sharing it. Mr. Mehul?
He has had to log out for some reason.
Okay, would you want me to do it, ma'am, since I have the CV? Oh, okay.
Wait. Can you see the correct one?
I
have 3 open on my desktop. I think, Rashmi ma'am, I will display your program, and in that there will be your CV. So, Mangala ma'am, if you would read from this CV, please.
Okay. Yeah, good evening, everybody. It's great honor to be part of this webinar. This is Dr. Rashmi Bagga, madam. She is professor and Department of Obstetrics and Gynecology, PGI Chandigarh. She is president of. Okay, that's all.
She is the president of Northern India Obstetric Gynec
President
Society.
of Northern India. I have seen in that previous thing.
Yes,
so now I welcome madam for the speech.
Yeah. My very good evening to all of you, and my thanks to Dr. Asha for involving me in this, and my regards to Dr. Hema Divakar. It's a pleasure to have you on the panel today.
Okay.
Now, as luck will have it, I was in the office with everything ready, and suddenly the power went away. I don't know, it doesn't happen. I thought office will be safer than home, and now I got phone, but Dr. Asha. So I can start with my first talk, my topic. The first slide was that we are going to talk about intrapartum monitoring of labor and the fetus. And the monitoring has to be both of the fetus as well as the mother so that we have a good outcome. And we are a resource limited setting. Therefore, in resource limited setting, having the presence with the current aims of having respectful maternity care and a companion in labor, it's a very helpful thing to have a companion who's already had a delivery. We generally choose that woman from the family who has herself had a delivery. So she's a better companion who doesn't get scared of labor or other outcomes and can guide the woman. So having that person will alert you to any immediate problem. She will immediately call the doctor or the nurse or whosoever is there that this problem is there. So with that, the traditional way of labor monitoring, the aim is that we detect fetal hypoxia and acidosis, and we intervene to prevent any damage due to acidosis. Hypoxia is reversible, acidosis is not. So the small interventive time period between hypoxia and acidosis is when we have to, that is a window when we have to intervene to prevent permanent damage to the fetus in the form of hypoxic ischemic encephalopathy. So the benefits that without monitoring, the fetal death rate was around 3 to 4 per 1,000 births, and with monitoring, it reduced several times, only 0.5 per 1,000 births. Next slide, ma'am. Next. So the methods of intrapartum fetal monitoring available to us are intermittent auscultation. This
Ma'am,
is
put off your
something
video. Your
available
voice is moving
everywhere.
a lot.
It is a low cost method. The second one is electronic fetal monitoring, also known as cardiotocographic monitoring. Is it better now? I'll just try. My power is also. Hello.
Yes, ma'am, please go ahead. Your voice is breaking a lot. Come closer to the mic, ma'am, and please go ahead.
Can you hear me? Yeah, please point out if there's a problem because explain. Is it still breaking? Okay. Okay, I'm right on the phone now. So we have intermittent auscultation, we have any tests, and also the presence of my voice better now?
Yeah,
A
better.
little better, ma'am. Please go ahead.
Can I have the next slide, please? Please. So when the intermittent auscultation is done, what it is advised is that you can either
Ma'am, we cannot
every
hear you
15
at
minutes.
all. Ma'am, we cannot hear you at all.
Just give me a minute, my power is back. I'm just logging in from my computer. Just again, okay? Just give me a second.
Okay, ma'am.
Yeah, I'm really sorry. I didn't expect this to happen, but
Chinmay sir, are you ready? If madam takes time to log in, can you take the first talk?
I'm logged in now. Okay.
Okay, ma'am. Please go ahead.
I've logged in. I didn't expect this to happen. That's why I sent my slides to you.
No issues, ma'am. Please.
Yeah,
Carry on,
I'm
ma'am. You're
logging out
audible
from the
now.
phone.
Yes.
Yeah. Am I audible now? I'm
Perfect,
logged out
ma'am.
from
Now
the phone.
it's fine, ma'am. Now it's fine.
Yeah.
We can't hear you at all, ma'am.
Ma'am,
We
you
cannot hear
muted
you at
yourself.
all. No, ma'am is not muted. Ma'am, your computer does not have voice. You need to be on your mobile for the voice. She can't
Ma'am.
hear us.
Ma'am, 1 sec. Ma'am, Dr. Rashmi, ma'am. Dr.
She
Rashmi,
can't
ma'am.
hear us. She can't hear us.
Ma'am, Rashmi, ma'am, can you hear us, ma'am? Ma'am, you're not audible. There is an issue with your computer. I think the microphone of your computer is not working. Now, ma'am, talk now, ma'am. Just say a few words.
Dr. Asha, I can't see the slides. They just went off.
Ma'am, we could not hear you. Therefore, I put them off.
Okay, now you're audible, ma'am. So let's continue.
Okay. Just come down. Yeah, so let's go on to the fourth slide. Yes. So the limitation of the intermittent auscultation is that we cannot pick up variability or types of decelerations. Other than that, it's a very good method to pick up any change in the heart rate, tachycardia or bradycardia. And the Doppler is better than stethoscope to get a good result. Next slide, please. So electronic fetal monitoring, the second thing which I will be talking about, we usually use external CTG and we do a labor admission test, which is called an initial electronic fetal monitoring in low risk women when they come in early labor. If that is normal, then we put them as low risk and they can benefit by less frequent monitoring by CTG and they can benefit by intermittent auscultation. Whereas if that picks up a problem, then we need to do more intensive monitoring and we put them in high risk. Whenever we find any abnormality with CTG, it must always be confirmed by a Doppler because a CTG may pick up a false trace as it can pick up a maternal heart mistakenly as fetal heart. This has happened. We've seen it also. Sometimes there is maternal tachycardia, a heart rate of 120 is picked up, and there was no fetal heart, which should be confirmed by Doppler to see that CTG is not picking up something abnormality. Next slide, please. So these are the two common, one is a CTG on the left side. This is a Huntley brand, a good CTG machine. And the right side shows a Doppler, which is a very useful method of intermittent auscultation. Next, please. So when we compared intermittent auscultation with electronic fetal monitoring, as you can see, the fetal heart abnormalities were picked up much more by electronic fetal monitoring. And therefore, the C-section rate also went up, but there was an advantage in neonatal encephalopathy rate going down. However, if you see the third column, intermittent auscultation with Doppler compares fairly well. The fetal heart abnormality picked up is much higher than intermittent auscultation with stethoscope. C-section rate is higher, but not so high. And the neonatal encephalopathy is good, is low rate, 1 in 3, 1, 2 only. Therefore, if where the centers which do not have access to electronic fetal monitoring and are resorting to intermittent auscultation, a Doppler is of far more advantage than using just a stethoscope, a simple handheld Doppler. The limitation of the results when we compare is that the cerebral palsy can happen due to an antepartum event also rather than intrapartum asphyxia. And based upon these data, the ACOG recommended that in low risk you can do either method, but high risk a continuous CTG monitoring is preferable. Coming to the next slide, please. Next slide, please. So, which are the women who are at high risk? We will have maternal factors, we can have fetal factors, we can have intrapartum risk factors. We're all familiar with that.
So I'll move ahead. Next one. The background is the interpretation of CTG is a complex situation. It's not that simple. And now we have so many guidelines available. The first one which came was the RCOG and NICE guideline, which came in 2007, underwent more revisions in the middle, and now we have a 22 guideline from this NICE guideline. Then we have a guideline from the ACOG, Society of Maternal and Fetal Medicine, and NICHD combined, which had a workshop in 2008, and they also categorize the CTG. And then we have FIGO 2015 guidelines. Now, what to do, which one to follow? Next one. So we just have 4 components of fetal heart monitoring in CTG. One is baseline fetal heart rate. Second is baseline variability. Third is acceleration. And fourth is deceleration. I will talk about each one of them with diagrams to make it clearer. So the baseline rate is something which we can pick up even with a simple Doppler. It is a mean rate over 10 minutes period, and bradycardia if it is less than 110, tachycardia if it is more than 160. Next, please. The second component is baseline variability. This is the biggest advantage of having a CTG. It picks up variability, which has a lot of bearing on fetal outcome. To identify variability, we examine a 10-minute segment of the CTG, estimate the highest peak and lowest trough, and visually quantitate the amplitude of peak to trough. So the absent variability is there is undetectable, minimal 0 to 5, moderate or normal 6 to 25, and marked or a saltatory pattern is a very high variability. Next slide, please. So here are the pictures of the variability. We have a silent 0 to 5 or a reduced, although within normal range 6 to 10. Normal here is 11 to 25, which is a good range. And saltatory pattern is a lowest one on the left side, which is 25, and that is abnormal. Next, please. Next slide, please. Next slide, please. So the factors which affect variability, if you have a normal variability, 90% of fetuses will not be acidotic. So it is a very reassuring finding to have a normal variability. If you have a reduced variability, you can have some physiological causes like the baby sleeping or preterm, or CNS in affecting drugs have been given like narcotics or magnesium sulfate or even epidural analgesia, or the baby may be hypoxic. And if the variability is increased, it is acute hypoxia or cord compression, for example, in the second stage of labor. This is also non-reassuring. Next, please. The third factor is acceleration. It is an abrupt increase in FHR, which lasts for more than 15 seconds, and the peaks is more than 15 beats per minute above the baseline. And this is an abrupt increase and abrupt lowering. What we define as abrupt is it should take place within 30 seconds, a rise and a fall. Gradual is when it takes longer than 30 seconds. Next slide, please. So this is a picture of an acceleration, which we call as reactive tracing. And you can see in the top, you can see that you have 3 accelerations shown in the graph. Now, with a normal variability. Now, absence of accelerations in a CTG is of undetermined significance, which means that acceleration is very important in an NST. When NST, we mean non-stress test, the test which is done in pregnancy, not in labor, to see whether the baby is okay or not as a part of biophysical profile. Their accelerations are very, very important. But in labor, it is still not clear whether their absence means anything bad or not. Next, please. So the fourth component is decelerations. A deceleration definition is the same as an acceleration, but in the opposite direction. A slowing below baseline, more than 15 beats per minute for more than 15 seconds. Now, decelerations can be of 3 types: early, late, or variable. The early ones are usually due to head compression or vagal stimulation. Late ones can be because of placental insufficiency, hypoxia, and further myocardial depression in the fetus. And variable is usually due to cord compression. And any deceleration which is prolonged is beyond 2 minutes. And any deceleration which is recurrent or persistent is when it is present with more than half of the contractions. Next, please. Now, early deceleration, this graph shows here you have a decrease and return to baseline during a contraction. Early deceleration, the onset of deceleration, the lowest point or nadir of deceleration, and the correction of deceleration, they all coincide with the onset, peak, and end of contraction. So like you see here the graph, the peak of the contraction and the lowest point of the deceleration are coinciding with each other. And usually these are more than 20 beats per minute, deeper with stronger contractions, and they may be present due to uterine contraction and advanced labor. Next, please. A late deceleration is a more sinister one. Here it starts and is deepest and recovers after the contraction. So the onset, the nadir, and the recovery is after the onset, peak, and end of contraction. Next, please. This can replace a late deceleration, which becomes with the fetus is severely acidotic due to severe hypoxia. This is myocardial depression. It can be worse than the one I showed previously because there it is shallow deceleration and it has no variability. So a shallow late deceleration with reduced variability is more sinister than a deceleration which contains variability. Next, please. Next, please. So the third type of decelerations is variable decelerations. Now, variable decelerations can be there without any relation with the contractions. They can be before, during, after. So they will be irregularly placed with the contractions. Now, the variable decelerations used to be earlier called typical or atypical. Now the terminology has changed from typical, they say variable deceleration with no concerning characteristics, and atypical are now called variable with concerning characteristics. So as clear from the names, the ones with concerning characteristics are the ones which are most dangerous. So when we define a variable deceleration, I will go to the next slide, please. I will give the concerning characteristics. So the typical variable, the ones with no concerning characteristics, what happens is usually they are due to a cord compression. So when the cord is compressed, the umbilical vein is occluded first, there is less venous return, low fetal BP, and reflex tachycardia. That shows the shoulder of the deceleration, a tachycardia just before the deceleration start. Then the next step is umbilical arteries are compressed after the veins. The compression of arteries leads to high fetal BP, baroreceptor response, vagal stimulation, and bradycardia. Here the deceleration starts. So when the compression is relieved, the arteries open first, BP falls, there is transient tachycardia. This is the second shoulder, which is the second high point after the deceleration. And when the vein opens, BP becomes normal, fetal heart returns to baseline. So this is how a variable deceleration is explained. Next one, please. So the one with atypical variable decelerations with concerning features, there are 6 concerning features. Loss of shoulders, which I explained, the small spikes at the beginning and end of decelerations, loss of variability during the deceleration, a slower return to baseline, a prolonged secondary rise in baseline, a continuation at a lower baseline, or a biphasic deceleration. In the deceleration, you have got 2 phases. I'll just show you the picture in the next slide. So a persistent atypical variable deceleration with a low nadir rate lasting for more than 60 seconds with slow return to baseline with absent variability is one of the worst forms of variable deceleration with concerning features. Next, please. These are 6 pictures. The one on the top left shows a variable deceleration with no concerning feature or a typical variable. You can see 2 shoulders, 2 peaks before the one before and one after the deceleration with some variability. The second on the right shows an overshoot, again a concerning feature. Then loss of shouldering. Then we have a smoothing of the trough, means reduced variability. then you have a late recovery, and you have a biphasic deceleration. So all of these are concerning features which are part of a variable deceleration, which used to be called atypical earlier, and now it is called variable deceleration with concerning features. Next, please. So we have then prolonged deceleration. A deceleration when it lasts more than 3 minutes is a pathological prolonged deceleration. And when it crosses 10 minutes, it gets called a change in baseline or a bradycardia. Next, please. Sinusoidal pattern is a pattern which you have got regular smooth oscillation resembling a sine wave, which has a stable baseline rate, variability is reduced, and amplitude of this up and down sine waves ranges from 5 to 15 beats per minute. This is a sinister pattern reflecting fetal anemia or hypoxia, and it has got high mortality. Next, please. You have a pseudo-sinusoidal pattern. In the next slide, you will just see it. After the sinusoidal pattern, next slide, please. The pseudo-sinusoidal pattern looks like a sinusoidal pattern, but it is not that sinister. There will be some variability present in it, and this can happen due to narcotics, and if it is transient and recovers, it is not sinister. Next, please. Next slide, please. So based upon understanding of the types of decelerations, we have a classification, and believe me, it is impossible to learn this classification. The simplest method is to have a printout of this in your labor room. We have put a printout of this on the back of every partogram so that whenever we find a problem, we refer to it and we classify what the CTEG is. So based upon these, understanding of these, the previous one, please, that slide. No, the previous one. Yes. So we will have every feature with given a, either it is reassuring or it is non-reassuring or it is abnormal. And the features I will revise: the heart rate, the variability, decelerations, and presence of accelerations is of undetermined significance. So we have to understand only these three features: baseline, variability, deceleration. If all of them are normal, we will call it reassuring. If it is non-reassuring, the rates are again given. You have to understand, but as a rule of thumb, it should be with less than 50% contractions for less than 30 minutes. Then it is okay. And also there should be no concerning maternal risk factors. But if the rates go further in the red zone, then it will be with more than 50% contractions for 30 minutes or more, even lower if there are maternal risk factors like meconium or bleeding, and prolonged deceleration and acute bradycardia. Next, please. So based upon these, RCOG FIGO has classified them as normal. All the features are not reassuring. Suspicious when you have a single non-reassuring feature and two are reassuring. And pathological when two are non-reassuring or single is abnormal, based upon the graph I just showed you. The same thing is called as category 1, 2, and 3 by the NICHD classification. Next, please. So category 1 will be, like I explained before, matching the normal or reassuring one. The baby is normal, there is no acidosis. And here, early decelerations and accelerations, present or not, are part of it. Category 2 will be indeterminate, doesn't meet criteria for either 1 or 3. And 3 is very well defined as absent variability with recurrent late decelerations, recurrent variable decelerations with concerning features, and bradycardia. And sinusoidal pattern, which is missing in the slide, it is also part of category 3. Now, how common are these CTG findings? The most common is category 2, which is the one which is most difficult to interpret. Category 1 is easy to interpret. You find it in 27% of the women. And category 3, which is sinister, you find it very low incidence, 0.1% only according to this data. Those are easy to identify. The problem is the category 2 because there are so many variables given. That is why having a ready referral, understanding the patterns of CTG, understanding the level of deceleration, the absence of variability is important, that each factor is clearly seen, and the more graphs you see, the more familiar you become with recognizing them. Next, please. So management of a CTG abnormality is that if it is suspicious, which is category 2, the intermediate one, is it pathological? Is it physiological? Is it because of uterine hypercontractility, maternal tachycardia, pyrexia, dehydration, low blood pressure due to supine hypotension? Is it because of epidural analgesia, sedation, or magnesium sulfate? We have to see those features and identify those, and whether she has any background problem like a fetal growth restriction fetus which will tolerate this poorly, then intrauterine resuscitative measures are taken to improve the uteroplacental blood flow and see whether CTG becomes normal, improves with these changes. So we do multiple interventions simultaneously, make the position left lateral, stop the oxytocin, give tocolysis, give intravenous crystalloid, saline or ringer lactate, give oxygen by mass, do a pelvic examination, rule out a cord prolapse or rapid descent of head, and look whether epidural top-up has led to a problem. Next, please. Because epidural analgesia is given quite often and it does lead to problem. If it is pathological, then we need to intervene to deliver the baby very fast. Next, please. Next, please. So the common drugs which can lead to changes, which will be in the form of, which will come in category 2, which is the middle one, non-reassuring and not pathological. Betamethasone can lead to reduced variability. Magnesium sulfate can lead to reduced heart rate variability and accelerations. Pethidine morphine we hardly use now. Epidural analgesia can lead to sympathetic blockage, hypotension, uteroplacental insufficiency, and terbutaline can improve the decelerations by relaxing the uterus. Next, please. So I just want to have a slide on this. What happens when you give epidural is that it can lead to maternal hypotension. And if maternal hypotension is not managed by giving a good bolus of IV fluids prior to giving epidural, that can lead to fetal hypoxia, bradycardia, or late decelerations, which has to be treated immediately with the help of alpha adrenergic agonists, phenylephrine or ephedrine, by the anesthetist, along with intravenous fluids to improve the uteroplacental blood flow. So this can happen due to maternal hypotension. Next slide, please. The second problem which can happen with epidural is that there is a sympathetic blockage by giving intrathecal opioids. There is no hypotension now, but the sudden uterine hypertonus. Why it happens is rapid onset of pain relief, this reduced circulating epinephrine, and epinephrine has got a beta mimetic effect. That beta mimetic effect goes and it leads to relaxation of the myometrium goes and it leads to uterine hypertonus. And this has to be immediately recognized by the anesthetist who is giving the epidural bolus and can be reversed with IV nitroglycerine. So none of us are familiar with these drugs. None of us should use them, but we should be aware that these situations can happen, which can be reversed by the anesthesiologist. Next, please. So next,
we'll have to speed it up a little.
Yes, but I'm almost the end of it. Just I wish I had the slide control. I could have run faster. Can you just go ahead? These I've already discussed. Steps of this. So CTG should be preserved for a minimum of 25 years, and all of our CTGs are on thermal papers, which fade away very, very soon. So if you have a CTG with a problem, please get a photocopy and preserve it for longer time, because this is a type of litigation document. Next, please. I will just skip the fetal blood sampling. We do not do it. So this is only from theory, because it's a difficult test to do with its own implication. Next, please. Next slide, please. Yeah, just come to the next slide, please. Yeah. So to summarize it, fetal heart monitoring is an important thing. Rather, labor monitoring is important. It is not just the contraction, it is the fetal heart, and both can be monitored very adequately, either by palpation and intermittent auscultation, or by using a Stoco probe and a fetal heart probe. And in high risk, electronic fetal monitoring is more important because it can identify reduced variability, which is an ominous feature. And that is the one which tells you the 98% are not acidotic. And if you have a non-reassuring fetal heart, the patterns of fetal heart which are going into the category 2, the middle one, we have to try the in utero resuscitative efforts, look whether we are giving any medications which can lead to these, because these are correctable also, and we can have a normal delivery if we are able to correct them by taking care of the measures. Thank you very much. I end with this. And I apologize for the glitches, but I never expected that the PGI power will just go off right at the last moment. I apologize for that.
That's not an issue, ma'am. It was a very good presentation. Would Dr. Mangala, ma'am, give a few concluding remarks about this talk?
Madam has given very excellent talk. It was again reminding us student life. So it is very nice, madam. Nice presentation.
Thank you, ma'am. You don't have to apologize, when you're doing it online. I think we are just grateful that we are able to meet each other online. And some glitches will happen, can't help it. So thank you so much for carrying on in spite of the glitches. And now over to you again, Sujya, to introduce our second session chairpersons.
Ms. Mehul, will you share the slides? Yeah. Moving on to the next session, it is ultrasound monitoring of labor. Our speaker for this session is Dr. Chinmay Umarji, sir. We have chairpersons, Dr. Kuntal Jadeja. She has been trained at St. George Hospital and King Hospital, London. She's currently the president of Rajkot OB-GYN Society, and she's a fetal medicine consultant. Welcome to today's session. We have Dr. Manisha Agarwal, ma'am, with us, who has 30 years of experience in the field of OB-GYN. She's currently working in Brahma Hospital for the last 26 years. And she has worked as a medical specialist in the department for a very long time. So welcome to today's session, ma'am. We have Dr. Deepa Saxena. Ma'am is actually a senior consultant and proprietor of Bridgedeep Hospital, Shahjahanpur, UP. Madam has done her master's from GSVM Medical College. She is a member of the Indian Association of Gynecological Endoscopists, life member of IMA. Her center is registered as an infertility clinic and ultrasound center. She has conducted endoscopic workshops and presented papers. Welcome, ma'am, to today's session. I would request one of the chairpersons to please introduce our speaker, Dr. Chinmay Umarji.
Dr. Manisha, if you would please introduce Chinmay, sir. Sujya, would you go ahead and do it?
Yeah, sure. It's an honor to have sir with us. He's actually a frequent speaker on our program.
Good evening all.
We have Dr. Manisha. Ma'am, please go ahead and introduce the speaker.
Good evening all. Thank you for making a part of this informative webinar. I am privileged to introduce Dr. Chinmay Umarji. He's MBBS DGO MRCP from Ireland, MRCOG London, fellowship in fetal medicine, consultant in Umarji hospitals. He's in charge of fetal medicine units, BJ Medical College, and Sassoon General Hospital. Welcome, sir. I invite you to take the talk.
Many thanks, Manisha ma'am. Can't thank enough Asha ma'am and the team for giving me this opportunity to be here and discuss a topic which is very close to my heart. Going online after Rashmi ma'am is going to be a challenge. However, I'll do my best to give justice to this topic. It's relatively new, and the reason why it is taking a while at our place in our country is probably also the laws which kind of restrict us. I started this off doing fetal ultrasound and intrapartum ultrasound around 5 years ago. And we've been doing quite a few of them. We deliver around 70 women in my private practice every month. And in good number of these women, we use ultrasound. These are the common indications which I think all of us use the ultrasound for. The first 5, including unregistered patients, high BMI, if you're suspecting IUFD, we strongly recommend that never disclose IUFD unless you have seen it on the ultrasound by two separate practitioners. Malpositions, malpresentations, and as we know, although abruption can pick up larger abruptions can be picked up on the ultrasound. The ultrasound has huge limitations when it comes to a fetal the abruption of less than 100 cc. Today, I'm going to restrict myself to this new topic called as ultrasound monitoring of labor with the help of to assess the progress of labor. Now, it's been ages. I remember my mother telling me that her dissertation topic was partograph. So I'm sure we've been using partograph for decades, if not a century now already. Mentally, I'm speaking, the formal partograph and then the simplified partograph, all of us know that it has changed our lives like mute charts, which make our patients safer on our labor rooms. But there is a large limitation. Repeated pervaginal infections are painful. If you go through the women's blogs where they talk about labor, you'll realize that they talk about pain, and especially they talk about difficult pervaginal examination and sweeping. If you look at the industry of gentle birthing, which has been coming up, and then everything coming out of it, say water birthing and lotus birthing and whatnot, majority of it has been provoked by pervaginal examinations because women are really scared of pervaginal examinations. Along with the pain comes the infections and potential low-lying placentae or cervical trauma, which causes antepartum hemorrhage. And I'm sure all of you senior teachers have seen junior doctors inadvertently even injuring the vagina during some examinations. Also, there is a lot of interoperator variation. The reproducibility is very low. Majority of our public hospitals have this protocol that when you take a handover, do what the JR1 or JR2 does is pervaginal examination of everybody on the labor room, although it may have been done 1 hour or 2 hours ago, because they want to know what is happening in their duty and they want to be absolutely sure about it, because the reproducibility is not there. And again, that leads to further confusions and infections and pains. And what we have realized over the period of time, that using ultrasound during labor is a very useful tool when we talk to the patient, her birthing partner, who in our labor room is along with them, and of course to stimulate her, telling her that, you know what, you're pushing and that's helping, see your baby is coming down. That visual feedback, which increases chances of natural birth, is very, very visible with the ultrasound. How do we do it is the first question. How do we monitor it is the next question. So let me start with how we do it. And I've taken these images fresh for you guys today while I was on the labor room. So as you can see, I'm on the abdomen and I'm looking at the presenting part, which is clearly seen over here as the vertex. I'm sweeping from midline to the left to patient's right, where I could see the spine. I'm just playing this clip again. So I've come over here. This is patient's right. So I can see the spine is on the right. Then I'm sweeping on the opposite side. And I can see that the orbit is on the opposite side. So I know that my baby's occiput is anterior. If you go to the midline again, and I know that my spine is on the right side. So this is right occipito anterior kind of position. Now I go transperineally, and this is how I keep my transperineal probe. And there are 3 positions in which we keep it. These 2 which I'm keeping it right now on, these are to assess head to perineum distance along the birth canal and to assess the cervical dilatation. I'm going to show you how in some time. So this is head to perineum distance. You can see the anterior table and the posterior table of the presenting skull. You can see the birth canal, and you know that your probe is on the perineum. So if I measure this head to perineum distance, it is 4.5 centimeters. And I'm going to tell you how to interpret that when you're monitoring a woman in labor. Another such example, 4.9 centimeters. This is one of the older cases. And now I'm using my probe in mid-sagittal plane, where I've got the pubic symphysis right in front of the presenting part. I'm trying to get the anterior posterior tables and the anus. I think the video will be clearer for this. And I'm getting the pubic symphysis over here. I'm coming to the lowermost border of the symphysis pubis, at which junction I draw a line along the axis of pubic symphysis and another line which is tangential to the presenting skull bone. And this is the angle which is called as angle of progression. And I'm going to talk about that also. The angle between the axis of pubic symphysis and the tangent drawn to the presenting part. And another such example, here the angle of progression is 117. In the previous case, the angle is more than 120, which is 125. Now, and here is another case where she is progressing really well, and I've got an angle of 149. Apologies for the quality of the image also. And of course, in the older days, we thought that you would need still to do a per-vaginal examination to ascertain cervical dilatation. But now with better probes and visibility, a transperineal ultrasound is getting better and better. And you can take a very good look at the cervical dilatation, as you can see over here. And this holds true for up to 7 centimeters of cervical dilatation. Let me see if I've put in video for you. Apologies, I think my masking is not working over here. But can you see the cervix there? So this is my presenting part, the birth canal. I'm tilting. Now I can see some maternal tissue on the outer side and I see my cervix. So it's a very easy technique, very reproducible, up to 7 centimeters. And this is something which I did, I think, 2 o'clock this morning. So patient was in labor, primary gravida, not able to push. Epidural had worn off, but she was not able to push. So I just put the probe transperineally. You can see the pubic symphysis is right in the middle of the head. So her head is well below the pubic symphysis. And let me just show you. So head was here, and now you'll see that the head is moving towards the right. Apologies for the quality of the imaging, but this is called a visual feedback. Can you see there is a movement towards right? Right is down, left is up. So this movement actually helps us a lot in ascertaining and kind of reinforcing on the couple that you know what, you're doing something and see it is working. And thus the new proposed sonopathograph is something which you can see over here. Here you can see that like a pathograph, it is talking about arsins, labor, oxytocin, amniorexis, amniotic fluid, and epidurals. Of course, it is talking about head position and cervical dilatation, which you can now ascertain with your ultrasound rather than 2 fingers. And of course, you're looking at angle of progression and head to perineum distance. An angle of progression more than 120, that is this line over here. I hope my cursor is visible up to the midline, is considered to have excellent perinatal outcomes when it comes to vaginal birth. Similarly, chance of vaginal birth is considered great if the head to perineum distance is less than 4 centimeters. And you'll be surprised to know this is irrespective of cervical dilatation. So even a 2 centimeter dilatation, if your vertex really well fixed and it is really low and perineum head to perineum distance is less than 4, there is more than 90% chance that you will deliver this patient vaginally, irrespective of the dilatation, provided other comorbidities and CTG helps as well, which Rashmi ma'am had so beautifully told us how to monitor, right? So I think there is an urgent need for all of us to graduate from per vaginal examinations to sonopartogram, and this in turn will improve our patient experience, make the birth gentler, and reduce the chances of maternal request for cesarean. Of course, there are disadvantages. For example, people may end up giving an unnecessary diagnosis that there is cord around neck, panicking everybody over there, which is not really necessary. Ultrasound has low sensitivity for certain other conditions, and patients may say that, you know what, you had ultrasound there, you were using it on me, but you could not pick up abruption, which we need to explain to the patients appropriately before you start using the modality. Cost of ultrasound machines is phenomenal compared to our fingers, and thus the costs could be one of the prohibiting factors. There is initial learning curve. I work with a fabulous team of doctors, but still it took us around a year to kind of sensitize everybody that we need to start using it, things in place, and then auditing protocols in place. And the biggest hurdle for us at times could be PCP NDT. So you have to keep informing your secretaries, keep doing your forms, make sure that the forms are put through and they're sent online. And that could be a big challenge for many of us in using intrapartum ultrasound. Just to summarize, what you need to remember is angle of progression of more than 120, head to perineum distance of less than 4 centimeter. Cervical dilatation can be estimated up to 7 centimeter of dilatation, and this has great reproducibility. Even you can ascertain station based on this. And of course, patient acceptance is great. There are advantages of counseling, and you have evidence when you have to take your patient for cesarean, you can document that there was non-progress as evident by HPD of more than 4 or AOP less than 120 and dilatation so and so. And you can have images to depict that you were correct and authentic. With that, I urge all of you to graduate yourself from gynecologist to sono-gynecologists and sono-obstetricians and utilize this wonderful modality on your labor rooms. Thank you, Asha ma'am, again for your opportunity.
Thank you, sir. Before I hand over to the chairpersons, I had one question. You said that you need to tilt to see the cervical loss. So when you're doing a transperineal scan, you just tilt till you're able to see the cervical dilatation. So which direction do you tilt?
Ma'am, with your permission, I'm going to share my screen again.
Yeah, please go ahead.
So ma'am, this is the angle which I use. So you have already seen the video. Let me just, yeah, this is the angle which I use. So I'm just below the pubic symphysis, or you can do it from the perineum, I mean, just above the foresheet as well. And I kind of put my probe transversely like this, and I tilt it downwards. So initially I'll see the presenting part, then I'm going down. Now I start seeing maternal tissue, and then at the end of it, I see a hypoechoic area like this, which is my cervical dilatation. So let us again see how it looks in real life. So I am at the presenting part. I'm going down, down, down. Now my maternal tissues have started coming in, and now I have a hypoechoic area right in the middle. I'll show you here. That
I got
hypoechoic
it. I
area.
got it. I got
Yeah.
it. Thank you.
Thank you.
Thank you. Over to you, Rashmi ma'am and Dr. Manisha.
And also Dr. Kuntal Jadeja is also here. So all of them can give
Yeah,
their
Kuntal ma'am.
So it was a very, very nice presentation, Dr. Chinmay.
Well,
I
thank
mean,
you,
it
Rashmi
is
ma'am.
actually so nice that it will be part of respectful maternity care if we can do it. The woman will
Absolutely,
be
ma'am.
very comfortable. I mean, totally agree. I noticed you were using a volume probe.
Yes, ma'am.
Yeah, so it has to be done with the volume probe only, all these measurements?
No, ma'am. No, ma'am. So we use either of the probes. Volume probe. So it depends on where I'm doing it, because volume probe is slightly gentler on the perineum because it has broader base.
Okay, got it. No, it
So
makes sense because
yeah,
we do
yeah.
have a volume probe, and if that is a better one, just because it's gentler, you feel.
Yes, ma'am.
Otherwise, the measurements are the same.
Yeah, yeah, yeah.
I
Absolutely.
mean, this is really, really nice.
Thank you, ma'am. Thanks a lot.
Dr. Manisha, would you like to add something?
Good evening, all. Thank you, Dr. Chinmay, for such an informative talk.
Thank you, Manisha, ma'am.
Thank you, Dr. Asha ma'am, for inviting me in such a wonderful webinar. Intrapartum ultrasound has certain advantages over clinical assessment because we can document the angles and head perineal level and all the things. It is useful in decision making and especially in slow progress of first stage and second stage labors. You talked very nicely about all these things. Thank you so much.
Thank you. Thanks.
I think Dr. Kuntal Jadeja has logged out. So yeah, thank you, sir, once again for that great talk. We will move on to the next session, which is the panel discussion. I request
you can expect some calls from us when we are doing it and are stuck somewhere.
Anytime, ma'am. Always at your service.
Thank you, sir. Thank you so much. I'm really honored with both my speakers. So if your OPD is running, you can log out.
Thank you so
And
much, ma'am.
if you want to be here, you're welcome.
Thank you, ma'am. I try my level. Thanks a lot.
Thank you. Thank you. Bagga ma'am is still here. No, ma'am has logged out. I think I will share the screen now. Or go ahead. Go ahead, Sujaya.
Yeah. So now we come to the final part of today's program, which is the panel discussion. We will be discussing cases of labor monitoring. We have Dr. Asha Jain ma'am, who will be the moderator for this session. Next slide, yeah. I've already introduced ma'am. She's standing for chairperson of Medical Legal Surgical Committee. So please support her. I request ma'am to please introduce
Food, Drug and Medical Surgical
Food, Drug and Medical Surgical Committee. Sorry, error on my part. So please support ma'am in her current venture. Hoping all the societies lend their support so ma'am can win this election. So moving on, I request ma'am to please introduce the panelists of the panel discussion. Ma'am? Yeah, we have, ma'am, are you there?
You are mute, ma'am. Ma'am, you are mute.
Asha, ma'am?
Yeah, Mehul, would you please allow me to share my screen? So, namaskar. We start the panel now. Panel on monitoring labor. So, we are going to discuss a few guidelines and we are also going to discuss what we do in difficult cases. So, requesting everyone who's present here to join in. We have Dr. Krishna Pawar, who's the secretary of Parbhani Society. We have Dr. Prerna Sehgal ma'am, obstetrician and gynecologist at Kalyani Hospital, Pathankot. Welcome, Prerna ma'am. Ma'am is the secretary of that society. We have Dr. L. Shanmugh Vadivu, who's the Secretary of Salem Society. We have Dr. Deepika Agarwal she's a consultant practicing in Saraipali, which is a very remote area in Chhattisgarh. We have Dr. N. Sarvana Kumar, who is MBBS from WIMS Bellary, and he's the organizing secretary FOXY South Zone Yuva Conference 2022. His field of interest is high-risk obstetrics and gynec endoscopy. He was the past secretary of Salem Society. We have Dr. Monica Pathak, who's caught up in a collector meeting right now. So she is the secretary of Raipur Society. We have Dr. Radhika Javia, who's the secretary of Rajkot Obstetric Gynec Society with us. So welcome, respected panelists. And here we take the introductory questions. I would not be addressing anyone in particular, and anyone can just take the questions. So, this is just to recapitulate what we are talking about. What is the need of labor monitoring? Why are we doing it? Radhika ma'am?
Yes. Yeah.
Requesting all my panelists, please keep your videos on.
Yeah. So basically, our
Mangala ma'am, you are also welcome to join.
Yes, madam.
Yes, please go ahead.
Yeah. So primary objective of labor monitoring basically is for maternal and fetal, both the sides. So for monitoring maternal vitals as well as for fetal cardiac monitoring, for looking for the fetal distress and for the labor progress on maternal side.
Yeah, so basically to keep the mother, the child and the obstetrician safe. And now, what are the advancements? I think we've already seen that. We have the CTG, we also have ultrasound and many more things. Do you know of any other advancement of technology? That has impacted labor?
Yeah, definitely. Sometimes what we see the CTG interpreted wrongly, and that can cause unnecessary cesarean sections. And I've seen people, I work in a medical college, so sometimes they tell that it is just a fetal tachycardia and then take a cesarean section unnecessarily. So that's one thing. But the other thing is, a patient who had come, and when we started, when we put a CTG as early as the labor, and then she went into abruption and we lost the baby. But then we were able to convince the patient that the patient had a normal fetal tracing when she came into labor. So it is both ways.
Okay. So, now there is such thing as a continuous monitoring. There is intermittent monitoring. So when are we going to use what? When are you going to do it continuous and when are you going to do it intermittent?
Yes, ma'am. I'll answer this question.
Hello,
Yes,
ma'am.
go ahead.
Hello. Yeah.
Yeah. Let Dr. Prerna answer, Deepika. And put your video on, please.
Ma'am, actually, it's not working, ma'am, I think.
My video is on.
No, yours is on, Dr. Prerna.
Yeah. So we have basically intermittent and continuous. Intermittent labor monitoring is for the low risk patients, and continuous monitoring we generally adopt for the high risk patients. We generally do an admission test, and if the admission test is normal, as Bagga ma'am said, if the admission test is normal, we categorize the patient as low risk, and then we can go ahead with intermittent auscultation. If the admission test is abnormal, if she falls in the abnormal or the high risk category, then we go in for continuous fetal monitoring.
Okay, so do you think the guidelines that WHO or FIGO or anyone gives, do they reach the periphery or they are just there in the books?
Ma'am, I don't think the guidelines reach the periphery. Even we private practitioners, we are not able to adopt them. What to talk of the, primary health centers and community health centers. These are only for books and only for institutions. This is what I feel.
Dr. Sarvana, sir, would you like to differ on this? You are muted, sir.
I just need that. question. Actually, I work both in a private setup as well as I work in a medical college. So protocols and guidelines, yes, we follow both both the sides. My only thing is, in the private setup, I have to be there on my own for every case. But in my medical college, I have my assistants or the other people who will be able to monitor. But sometimes there also we miss because it is the interns sometimes who be there to monitor, but they are not updated with the guidelines. That is one problem.
Yeah. So basically, what we are trying to say is that these guidelines need to go down to the lowest level where it matters, because all the deliveries are not happening in very high up centers. So if we are talking about reducing maternal mortality, these guidelines have to go down. Now, does monitoring have anything to do with the patient's preference? Do you get patients who are not willing for a PV?
Yes, ma'am. In private practice, we get a lot of patients, you know. They are those typical Chinmay kinds. You can't even touch them. At the simple touch of your finger, they'll be jumping like anything.
So how do you manage those cases?
Ma'am, they simply ask for cesarean and we have to, you know, listen to their request.
Yes, and most of the time what happens is that if we delay, like they are actually they wanting normal vaginal delivery, but they are not willing for per vaginal examination. Then mostly it happens that we have to counsel them in such a way that either you have to decide it now itself. Most of the time what happens that they will not allow, and then finally at full dilatation we have to go for CS. Then they will agree because then the pain will be unbearable. So most of the time it happens like that. Then when patient is not allowing for vaginal examinations, he's definitely going to go for cesarean section. They will tell on their own after 6 to 7 centimeters.
Okay, but
we all know that sometimes the patients, because I am a male gynecologist, sometimes some patients are very skeptical about me examining them. I allow my staff nurse or sisters to do a PV examination and inform. Maybe midwives are there who will who are able to convince those patients to undergo a vaginal examination, and they inform me. But then at the final point where the patient has the urge to push, then probably they are agreeing to examination and delivery.
Okay. So what are the mistakes that we make in labor monitoring? Whether it's a big hospital, a medical college hospital, or a small PHC, what are the mistakes that happen in labor monitoring?
Ma'am, I think the proper training of the nursing staff is must, as per my, in a private setup, how to plot the partograph and how much the augmentation of syntocinon should be there. There is the place where the mistake there are chances of mistake happening, and how to monitor the fetal heart rate.
You know, Dr. Bagga ma'am showed a graph, and when she said that intermittent auscultation had almost equal results to continuous monitoring, right? What could be the cause? What could be the cause? How is it that a continuous monitoring and an intermittent has the same result? What actually happens is you put that CTG and you think your job is done, or your staff thinks the job is done, it's making a sound, and there's nobody actually looking at it. So that is a very, very major pitfall, because CTG is available everywhere and there's no one to actually look at it and interpret it. Then sometimes the printer is not working, the print is not coming. But actually having the CTG or not looking, that is the most important thing. Now, you've been doing labor monitoring and something happens. How do you convey that to the patient? How do you convey that to her support team, the patient, her husband? How are you going to talk to them?
Ma'am, suppose the fetal heart tracing is getting abnormal, so it's very easy and convenient to show it on the graph that this is touching the red line. So when you show it on the graph, they immediately get convinced, yes, there is something wrong happening with the baby. And if we tell them that we'll stop the Pitocin drip and we'll give fluids and we'll try for some more time, if it comes back to normal, fine, or we'll have to go in for a cesarean. So they get convinced very easily.
Okay, do you think you need some other speciality as well to counsel? Or you as an obstetrician are enough?
If she is my bookcase, ma'am, she has full faith in me and she listens to what I say.
So now we come to the cases, and this is the first case where a dichorionic diamniotic twin, she's 30 years old, 37 weeks. She is in labor and she says ki abhi tak I've been normal, so I want a normal delivery. So when it is a DCDA twin, what is specific? How are you going to monitor her? When she has come to you in labor, what are you going to see?
Ma'am, in case of twin delivery, I think admission ultrasound should be done to know the presentation of both the fetuses. Because if the first fetus is non-vertex, that becomes an indication for cesarean. So if we find that the first fetus is vertex, then we are kind of carefree that yes, she can be given a trial of labor. And then she will need 2 fetal monitors. In case of DCDA, at least we are not tensed about the twin-to-twin transfusion syndrome occurring because they do not share the placenta. They have separate placentae. So that way also we are kind of carefree.
So there is no TTTS here because it is DCDA. But supposing there is discordant growth, that can still happen.
Yes, that is possible.
So now if there is discordant growth and the first baby that is coming down is the small baby, would you try for a normal labor or would you want to do a cesarean? If you have a small baby, if you have a growth retarded fetus, would you try vaginal delivery or you would take for cesarean?
No, if the baby is vertex and the CTG graph is coming out normal, I think there is no harm in giving a trial.
See, I asked you a very tricky question. It's not here. What I said was that if the baby is FGR, the baby is growth retarded. It is at 37 weeks, but when you have an FGR means definitely there are Doppler abnormalities. Are you going to take her for delivery or cesarean?
No, if there are Doppler abnormalities, definitely I'll go in for a cesarean.
Dr. Radhika, Dr. Sarvana?
Madam, if there is a Doppler abnormality to the extent of reversal of flow or something like that, then probably I would do a cesarean section. But if there is a mild Doppler abnormality, not otherwise, and if the CTG is going to be fine and the fluid is going to be okay, then I will allow, as long as when I put the continuous monitoring for this baby, then probably it's many times it comes out vaginally.
Okay. So now the first baby has delivered and the second one is transverse slide. What are you going to do?
We can try external cephalic version if that works out well and good, or else we can go in for internal podalic version and take the baby out as breech.
Okay. So you are not doing a cesarean unnecessarily over here. Okay. But now she has come for delivery. Would you want to counsel her that she might need a cesarean? Is that part of your counseling?
Yes, ma'am, definitely. Because
definitely, because the second one is or even if the first one is a growth retarded, it will definitely come out. But we have to explain that if
there's an increased chance of cord prolapse, abruptio placenta. There's an increased chance of the twins get together. So there are so many other factors which may have an implication for doing a cesarean section. So we would counsel about all these things, that they have an increased chance for cesarean section and operative delivery in these patients.
Okay. So now we have this baby. The labor is going fine, but what are the indicators where you think you want to do a cesarean section? What are the triggers that would suggest a cesarean section?
Ma'am,
You have the first vertex and there's no cord prolapse, but what are the indicators where you want to shift this patient and do a cesarean instead of continuing with normal delivery?
Fetal distress.
Yeah, if there are signs of fetal distress, if we feel that suddenly she's going into hypertonus and we are suspecting abruption.
Okay. You are monitoring her on a partograph, right? You're monitoring her on a partograph. So what trigger on the partograph where you want to take her for cesarean?
If she doesn't progress well, I mean, if her cervical dilatation is not proper.
If you touch the action line, you take an action. Simple. Now, if there is one baby with distress, the other is doing fine, what would you do? She is in labor, one baby has distress, other doesn't have distress.
For her, ma'am, both the babies are equally precious. So if one baby is in distress, we will have to go in for cesarean.
Okay.
It depends
Anybody
upon the
wants
stage
to
of
add any?
If it,
Yes,
it depends
sir?
upon the stage of the labor. Suppose she is fully dilated or 8 centimeter dilated, then probably I will accelerate the labor by using a vacuum. Especially vacuum is better for these babies. They are smaller and they may come out easily. And then think of delivering the other baby also, because the time to shift the patient for a cesarean section is almost equivalent to delivering through operative delivery if the patient is almost 8 to 9 centimeter dilatation.
Okay, so that is the trigger point, that if she's 8 to 9 centimeters, then you deliver vaginally, otherwise you deliver by cesarean section. It depends on how much dilatation and the descent that is there. Like all obstetrics, again, it's something in middle. Now, this is another case where this is an uncomplicated previous scar, 29-year-old, she's 39 weeks. Her first cesarean was for failure to progress. Now, in TOLAC, what is the risk and how are you going to monitor this patient?
The biggest risk in TOLAC, ma'am, is of uterine rupture. I mean, the scar giving way. And this has to be monitored by, first, before we allow her to go into labor, we should see the scar integrity. It has to be more than 3.5 millimeters. During labor, we have to check for scar tenderness, and there should not be uterine hypertonus. And she should progress well. I mean, on the partograph, she should not be touching the action line.
Are you comfortable giving oxytocin or not to such patients?
Yes, ma'am, low dose oxytocin can be given. There is no contraindication.
Dr. Sarvana, Deepika?
Yeah, for a
Dr.
TOLAC, it is
Radhika?
the patient counseling which is very important. She has to be prepared for a TOLAC and she has to agree for it, because all the Western texts give a number for a TOLAC. But what our patients are, in spite of telling all those things, we tell them about this rare incidence of scar rupture. They may not be willing to undergo a TOLAC. So that has to be properly counseled to the patient and tell that there, if we have a chance of a scar rupture, we have to take her for an emergency section. And also there may be chances that there may be a fetal distress or the fetal. So all those things has to be properly counseled. But I think oxytocin can be given without much of a problem. It is only the induction of labor in a case of a cesarean section that is more problematic, because we are not able to control properly the contractions. Whereas if the patient has already gone into labor, spontaneous labor, and we put an oxytocin drip, then probably she may progress very well once we monitor her continuously.
So what are the signs of impending uterine rupture?
Yeah, we put her on a continuous monitoring. The earliest sign may be a fetal tachycardia or a fetal heart rate abnormalities. And also the patient will be on a half an hourly pulse rate. Maternal tachycardia as well as fetal tachycardia may be the earliest signs of impending rupture.
See, there is a little bit of separation, but there is not a full rupture. Will you be able to detect it? No. No, I don't think. So, how would you balance benefits of vaginal birth against risk of uterine rupture?
Ma'am, vaginal birth is very, very convenient for the lady. Plus, it prevents future complications in her, complications in her future pregnancy, like low-lying placenta, placenta equita, then subfertility. It is also cost-effective, vaginal birth, as compared to a cesarean. But at the same time, during trial, if she lands into uterine rupture, then that's a catastrophe.
So, what are the criteria? Where do you want to convert a TOLAC to a cesarean?
If we find there are signs of uterine rupture, when we feel that the scar has already given way, the first thing, as Dr. Sarvana said, there'll be fetal heart abnormalities, there'll be maternal hypotension, there'll be loss of station, the patient will complain of severe pain.
It's not. The thing is, we are talking about impending rupture. So how would you diagnose an impending rupture? It has not ruptured. The patient is continuously being monitored. So you tell the relatives, if something like this happens, you tell your paramedical staff, if something like this happens, call me immediately. So what are those signs that you are looking for?
Maternal tachycardia, fetal tachycardia, severe pain over the abdominal scar. And at times the pain persists even after the contraction is gone.
Okay, so that is a very important point. Dr. Sarvana, you want to add something here?
Nothing much, madam. Yes, we only thing is in between contractions. Yes, probably the patient may be having pain. And one particular case I saw where it was a rupture. The patient was screaming the whole night, it seems, and suddenly when she ruptured, she had no pain at all. She slept nicely, and only in the morning they detected that the patient had a rupture. So that also can happen.
Okay, so if the pain suddenly becomes less, that is a catastrophe. That is a catastrophe. So that has to be watched for. Now we proceed to the third case. Deepika, can you hear us?
Yes, ma'am.
Okay, you are still not able to put on your video?
I think it's not working.
Yeah, it will work. I've sent you a message.
Okay.
It says she will start video later. So now this is a case of PIH and she is in labor. So PIH, is a normal delivery, a vaginal delivery better or a cesarean delivery is better?
If patient in labor and FHS is normal, then we will try for a normal delivery.
Okay, which is more beneficial for the patient for a case of PIH? Radhika ma'am?
Yes. Yes, I think for if the PIH is not severe and it is well controlled with medicine, definitely vaginal delivery is better for her rather than going for cesarean./
So when a patient with PIH has come or she has come in labor and you see her BP is 150/90, okay? What else are you going to check for when you take her in labor?
Ma'am, we have to see her latest blood reports if she has undergone. You have to look for the if other symptoms like urine albumin and other things, whether she is going into
liver enzymes, platelets.
Yes,
okay.
Platelets and everything, yes.
So what does the patient tell you where you think that this patient might go into eclampsia? What are the triggers?
She'll have severe headache, ma'am. She can have flashing of light. Then she might complain of epigastric pain. Then she can have vomiting also.
Blurring of
Sometimes there'll be blurring of vision.
Okay. So, how are you going to ensure a safe delivery in a patient of PIH? This is open to everyone. How are you going to ensure a safe delivery in a case of PIH? Radhika ji, you're muted.
Okay. For safe delivery, we have to actually go through the partograph properly. We have to keep on monitoring her, that she's progressing properly, keep on monitoring her blood pressure also, and fetal definitely.
Okay, so do you want to put a CTG here?
Yes, we have to put the CTG.
So you want to put a CTG here. And when do you want to take her for cesarean?
If her blood pressure is going very high, if there are alarming symptoms of eclampsia, or there is a fetal distress, that is the only, or if there is no, labor progress is delayed, going beyond the action line.
Acute pain abdomen?
Yes, we have to. Yes, definitely. If we see the signs of
If there is pain abdomen and the uterine consistency changes, that is another trigger. So, because abruptio can be one complication that we have to be careful about when she has acute PIH. And then once she has delivered, what are you afraid of?
Postpartum eclampsia.
And?
PPH, both.
PPH.
Yes. So these are two very, very important complications of PIH, because she might have postpartum eclampsia and she might have PPH because of altered blood products, right? Her clotting profile has changed. Eclampsia, PIH is a multi-system disorder. So, any other pointer for anybody who wants to deliver PIH by any of the panelists?
I would be liberal in using operative delivery once the patient is fully dilated, because sometimes the BP shoots up very near full dilatation. So I always have labetalol in hand, and also keep a vacuum or a forceps ready with me at the time of delivery, and all the measures to tackle the PPH.
Sir, and what about Maxilf?
Maxilf, yes. If the patient has imminent symptoms, I would definitely give Maxilf, because handling both will be difficult. Both the eclampsia as well as the PPH will be very difficult. So I will definitely have to. I will give a Maxilf for the patient.
So, what dose of Maxilf would you like to give, and what would be the route?
We follow this SIBA regimen, 4 gram IV loading dose, and then we give 1 gram per hour. So that will be the that is a continuous magnesium sulfate dose. We have calculated how to measure and put the dose, and we have pasted in our labor ward and everywhere.
Okay, so that is one big trip that you can stick it everywhere, and you need to also think of Maxilf when you are monitoring a patient in labor. Now we come to our fourth case. This is an impending scar rupture, and I think we've also dealt with this. Okay, now a patient who has had an impending scar rupture, would you allow her a trial of labor next time or not?
I think no, ma'am.
No.
No.
You don't want to allow it next time.
Yeah, ma'am.
Now this is the next case where she is 28 years old. She has gestational diabetes, is well controlled on insulin. Now at 38 weeks, she has been induced. So if you induce someone with GDM, what are the specific monitoring requirements? The regular what you do for labor is fine, but what extra do you do for gestational diabetes?
Ma'am, urine
How was the blood
acetone
sugar
and the
monitor?
blood glucose monitoring.
You would do urine acetone and
And the blood glucose
Sure.
monitoring 1 to 2 hourly.
So how frequently would you monitor her sugar?
Ma'am, 1 to 2 hourly. 2 hourly around.
1 hourly or 2 hourly?
Yeah, ma'am.
Radhika ji, how frequently would you monitor her sugar?
Yes, I think too early is well enough. If she doesn't have any other complaints and if she's going fine too early, we can check her sugars.
See, we are going to give her Actrapid, right? If
Yeah.
her sugar is high, we are
monitoring.
going to give her fast-acting insulin. So this Actrapid, what is the duration of action of Actrapid? It's 4 hours. It's 4 hours. So there's no point in repeating your sugar more than 4 hours, less than 4 hours, because you cannot go on topping up her insulin, right? So you've taken her test, then you've decided the dose you want to give, and then you also will neutralize her D5 drips. That has to be there. You have to neutralize her D5 drips. Now, if this baby is big, even at 38 weeks, you have induced so that the baby delivers fast. What are the signs that, this baby could go into a problem because of its size? Clinically, what do you see?
Clinically, there may be a delay in the progress of labor. She'll not dilatation and progress. The descent of the fetal head may be compromised. It may take a longer time. That itself is an indication that the baby is a macrosomic baby.
Yeah. So now we all know that there are babies who are high in weight and they get shoulder dystocia. But can a normal weight baby also get shoulder dystocia? 2.8 kg baby, can it get shoulder dystocia?
Of course, we have seen patients who are having difficulty delivering the shoulder. We immediately go back to the manuals, even if it's a non-diabetic patients. Even with 2.8 and 3 kg babies, we are seeing babies having shoulder dystocia. And sometimes we have to resort to all these Rubens manner and other things.
So when this baby is, labor is prolonged. We've read that term, prolonged. How much prolonged is prolonged? When will you say this labor is prolonged? 6 hours, 12 hours, 18 hours, 24 hours. When are you saying it's prolonged?
Ma'am,
you're muted.
Yes, we have to see the partograph actually. If it is showing prolonged labor in that, then definitely it is prolonged. It should not cross
that
the
is
action
agreed,
line.
but I'm just asking you, what is it usually? Once a woman goes into active phase, WHO has defined active phase now at 4 centimeters, right?
Yes.
So beyond 4 centimeters, what do you expect?
Generally, in 6 hours, we should deliver. So if it is more than 6 to 8 hours, then it is a prolonged.
Sarvana, sir?
Yes, at 4 centimeters, the labor progress should be relatively rapid. But suppose if she stays at 4 centimeters for another 2 hours or another 3 hours, then that triggers that the patient is not progressing very well.
Exactly. So basically, you are not going to wait for 6 hours. You are checking her every hour. As per the WHO guideline now, she has to be seen every hour. And for 2 hours, there's absolutely no progress. The dilatation is stuck. The head hasn't come down any further. So that is your documentary proof that this baby is not progressing, and you would then go ahead and do a cesarean section. So is that what you're going to do, or you're going to try to augment with oxytocin? Means she is stuck at 4 centimeters. So will you try oxytocin or you would not try? Yes, Deepika?
We can try, ma'am, I think.
So what are you going to see before you start oxytocin? The head rotation.
Ma'am, pelvic adequacy, cephalopelvic disproportion, maybe rule out.
Yes. CPD has to be rolled out whether the head is
engaged
rotated.
Rotated,
And another thing is, what I learned from my teacher when I was a student, that if the cervix, which was well applied to the head, suddenly starts hanging loose, it is a sign that this baby is not going to deliver. So that is a very basic clinical sign that a cervix that was well applied suddenly starts hanging loose. So you're not going to see that patient going to deliver. So this patient who is diabetic had gestational diabetes. You've done her cesarean section now. Okay. How are you going to monitor her post-operatively? Are you going to continue her insulin regimen? Are you not going to continue insulin regimen?
No, post-operative, we have to, the same insulin regimen is generally not continued, because the first is she will be nil oral, at least for 6 to 8 hours, she won't be on anything. So we have to monitor her every 4 hours, we will monitor her sugar levels. And when she starts the fluid, and then slowly we have to start her insulin, if at all required.
Early breastfeeding is very much advised because it causes.
Yes,
early breastfeeding is advised because it actually reduces the maternal sugar also to some extent, and also it can prevent fetal hypoglycemia. So resort to early breastfeeding, and then monitor both the mother and the fetus, because these babies are very common to go for hypoglycemia. And the mother, probably I will wait for 1 day. The next day I will do a fasting sugar and then the postpartum sugar. And if they are on a very high insulin, they probably need half to 1/3 of whatever insulin they were earlier needed. And that sort of an insulin I will start and see how she progresses. Because all these placental hormones, the insulin resistance have gone, then probably she has to do well with without all these hormones.
Okay. So when do you think she can go back to oral medication?
Oral medications?
Oral medication means her sugars are persistently high. She has not become non-diabetic because 30% are going to continue being diabetic. So she is one of those 30%. So are you going to give her oral medicine, and when are you going to start that oral medicine?
Third.
Yes.
I probably will start her oral medication when she comes for her suture removal at that time. So she will be on insulin.
Exactly. Yes. You will continue with her insulin till her wound is healed. Because with a wound in situ, you do not shift the medication. So, and then she continues with the oral medicine. You can take a physician to help you in that. Now we come to the last case. This is a 32-year-old. She is a preemie. Her BMI is 42. And she comes to you at 37 weeks. She has nothing. She doesn't have PIH. She doesn't have diabetes. But just because of her obesity, she is considered high risk. So what is the high risk related with obesity? Why is obesity considered high risk? Radhika ma'am?
Yes, in obesity, when she comes in labor, then there are chances of her getting discomforts during labor. Breathlessness and other problems definitely happen. And after delivery also, she is considered high risk because of the chances of DVT and other complications because of the obesity.
Okay. Sarvana sir, you want to add something to that?
When she comes in labor, patient with BMI of 42, the first thing I will be concerned is IV line, and then securing an IV line may be a difficult thing. So I will have an anesthetist also with me, and also inform the anesthetist, because many times these patients can land up in cesarean section, and they have to be prepared. The anesthetist as well as we have to be prepared. And another a gynecologist also may be helpful in handling these patients for doing a cesarean section. And the labor table and the comfort of the patient and lying down and delivering is also a problem for these patients. So a comfortable labor couch,
she cannot
if
fold
the
her
couch is
legs.
very small, if the couch is very small, then I can put her on the regular bed itself and then deliver her rather than using a.
Yeah,
and
but
I would
sir,
be
what Dr.
not
Radhika
very.
said, na, it is difficult for her to take that position to deliver.
Yes.
So would you consider her to deliver her in some other position?
Maybe squatting position may be okay, but I have not tried any squatting position for my patients.
Okay, I have tried it because I used to practice in an area where I regularly got patients with a huge BMI. So, sitting, they need to hold on to something, they need to sit on something, and then, because that is what gives their lungs a little capacity. So, those logistics have to be managed. And now, how are you going to monitor the fetal heart? Sometimes even a Doppler is not enough.
Yes. We have to see the ultrasound many a times due to obesity. Doppler also won't be able to. And as you said, ma'am, we also try in these obese patients. Generally, they are not able to bear in lying down position. So squatting position for bearing down till she gets full dilated, and at the end, towards the end, when we feel that now the head would be coming, then we make her lie down, and that would be more comfortable for this kind of patients.
So I keep the head end up still and then try to deliver. Yes. So what you want to give her some analgesia? Labor analgesia, epidural, do you want to give on such a patient?
Ma'am, it can be given, but depending upon the anesthetist, if they are ready with monitoring and everything, being present at the during the full time of the labor, if they are ready to be present, because many a times it happens that the catheter is very difficult to handle it with the patient's obesity and everything.
Yeah.
So
now the risk is the same. You already enumerated that we could have deep vein thrombosis, we could have PPH, and it's more difficult to detect. So are you going to, you will mobilize her early, but do you think you're going to give her Lonopin or something like that?
Yes, definitely. We are giving
you're going to,
even with
you're going to give her low molecular weight heparin?
Yes.
Which dose and for how long?
I usually start after 6 hours to after delivery, and then I give it for a week.
Okay. So the thing is, you want to say something, Dr. Radhika?
Yes, we generally don't prefer giving in all the patients. If we
we are talking about these obese patients. We are talking about
all
these
the obese patients. Yes, all the obese patients we are not giving, only if she is not mobilizing, not able to do all the things, and we feel then only we give.
See, if you do not give her in time, that means 6 to 8 hours after her cesarean, she is going to develop swelling of her feet on the 3rd day or 4th day. And then you will have to give it for much, much longer. So it is always better, and the anesthetist will always advise that start after 6 hours. So this patient, how are you going to counsel her about, that she might have to go for cesarean? She has to, when she comes to you and she's pregnant, how do you counsel her about controlling her weight?
Ma'am, diet, we have to be very specific. We have to tell the patient and the relatives both that weight gain for her, even little bit, is not going to help in any way. So proper diet is to be advised to her, what she has to take and what she should avoid. And other thing is daily regular walking and mobilization is must. Both the things we have to explain during her antenatal period.
Okay. So now we come to the end, and that is I need take-home messages from you, and then we can end the session. Thank you so much. Thank you so much. Dr. Sarvana, Deepika, Radhika, you have taken the panel, pulled the panel along. Thank you so much. Thank you, Mangala ma'am, for being here.
Yes, ma'am.
And just take home points from everyone before we end the session.
Yeah, be vigilant. Anything can go upside down during labor. So always don't leave the patient alone.
Okay. Radhika
Yes,
ji?
yes. I think at the end, what we generally follow here is that at the end, when the patient goes from here, both mother and child has to be healthy. That is the main thing. So it's not always that we are they're going for vaginal delivery is always going to be the best. Ultimately, it's our duty that both child and mother are safe at the end. So it's not always we have to go for vaginal only or liberal cesarean. Sometimes if we feel, then our aim is that mother and child are healthy.
Deepika? Mangala ma'am?
Yes, madam.
One take-home point from you, ma'am.
Yeah, it is. We have to make it regularly monitoring the almost all patients in labor, whether it is be risk or high risk. Depending upon that, we can, continue the monitoring, or maybe we can progress. Depending upon the progress, we can. So we have to keep the CTG and everything regularly. We have to use it.
So I would like to add one thing here, and that is that labor monitoring does not end just with labor. We have to train the patient for delivery in her pregnancy, and afterwards we need to teach her physiotherapy, because in the old days, when many patients were delivering vaginally, there were that many more prolapses. So everything has its plus and minus. Therefore, we have to take the patient as a whole, monitor her in labor, before and after. So thank you. Thank you so much for being here. Thank you all my audience for being here. Hope to see you next week. We are doing endometriosis. I hope all of you join in. And thank you, Corona Remedies, for being our academic partners. Thank you, Sarvana sir. Thank you so much, Mangala ma'am, Dr.
Thank you, madam.
Radhika,
Thank you.
Deepika.
Thank you.
Namaskar.
Thank you, ma'am.
Thank you, madam.
Thank you.